a well-known psychiatrist, and he is going to talk on somatization. We all face day-to-day in the practice, clinical practice, somatization. He's going to talk about that. So that is what we thought that we should include. And the last talk, which is the Dr. Utkarsh Patel. He's a neurophysician, and he takes us left, right, in and out. He throws us a case and then he says, now diagnose. He'll give us a clinical scenario. So you all are going to face that as well today. He has been doing that to us, being cruel with us, on many webinars. He will conduct the webinar, he will have slumber cases, he will have myelopathy cases, he will have cervical cases. That's what we thought that, we should have him with us today. So these are the talks which we are going to include in the coming session. And afterwards, we all will go for the dinner at Radisson Blue. That's where we will have the quiz. And we'll give you all the certificates, and those who attend that will be given a set of instrument as well. So do not miss that. We all have to be there in the quiz. And I'm sure the quiz will be different than what you have seen so far. So it's going to be different as well. And that's where Dr. Ajay is going to talk about endoscopy, when not to do. So everyone would put the scope into it, when not to do. That's very important. So that's what you need to learn as well. Tomorrow, what are the cases we have lined up? And I just need to brief you about those cases. Kyphoscoliotic deformity. So that is the ankylosing, coronal and sagittal deformity. Both together, and how do we handle that and what we do for those cases, that case. So that is something which we'll be showing live on OT1. OT1 second case will be the dorsal stenosis and lumbar stenosis, tandem stenosis. Then OT2 will have the C1, C2 osteoarthritis. Dr. Shrivastava is going to demo about the transarticular. All the patients are in. So that is why I can confirm these cases. Then these OT2 is the alpha S1 UBE. I'm sure some of you may have become a fan of microscopic surgeries and endoscopic surgeries. So it is something our own Dr. Amit, who got trained from Stavya, is going to demo two cases, one after another, alpha S1 and L4-5 stenosis. The OT number 3 has got kyphoscoliosis deformity. And our own Dr. Amit Jhala is going to demo that, and followed by Oli. Again, he will be showing the case as well. And from 5 to 7, we have specially sort of designed this documentation, how to do documentation, Dr. Pankaj Patel, followed by 40 minutes of talk of Dr. Mahendra Joshi. And he is the one who has written a book on medical negligence. With that kind of person who will be coming. So 5 to 6:30, from 6:30 to 7, you can ask personal questions. That is what we didn't want to go live on that. So today from 6 to 8, we will have live program, live auto TV. So anybody want to attend, they can attend. That's what we have announced. And tomorrow between 5 and 6:30. And 6:30 onwards, 6:30 to 7, any personal question, we can have the legal experts, they will answer and they will guide us. So that is how the program has been made. And 7 o'clock onwards, we will have the. So please be with us. If there are any questions, queries, I'm sure everybody is around. You are also here, and you can always ask and be part of the live webinar. So we can go live now.
Yes, sir.
Yeah, we can go live. Yeah, it's all live. Thank you. Thank you. So now over to Dr. Shrivastava for the my worst case. Thank you, sir. Thank you.
Thanks a lot. So it's important to talk about your extremely important. So I'm going to present this my worst complication. So a 50 years old male, he presented with us with cervical PID. It was a very common C5, C6, which usually we see, but with neurological deficit, and that was the picture. There was significant compression, and that's why he had myelopathic signs and symptom also. So we did discectomy and fusion, and he took full diet till 7th post-operative day. On 8th post-operative day, he had dysphagia, odinophagia, and neck swelling. And now you know what you are thinking. So this was the plain X-ray. So usually you think whether your graft is dislodged, some compression somewhere, there is a problem. But you can see this graft is properly placed. I used to use only bone graft till late I used to use this, and that was a very common thing to do without any plate if it's a stable spine. Now you see the prevertebral space, the width is significantly increased. It means there is prevertebral collection there. Okay. And so we opened the 2 stitches, and then we found there's a mucopurulent frothy discharge. And we put the methylene blue through the mouth, and the leak was positive. So it was a case of esophageal perforation. So we give a reference to the general surgeon, and general surgeon was opinion was taken, and he came and he said that yes, they will be re-exploring the area. So he started the re-exploration, and disaster during re-exploration. The search of minor leak, it became a 2-centimeter tear. Okay. And the general surgeon planned a diversion at a later date and put rise tube in distal esophagus through the neck wound. They had some old age technique that there is a diversion and the tract forms, and we believed that, and we went ahead and he did this, and antibiotic and dressing continued for 4 days. And this 4 days was 4 decades for me, and it was very agonizing, and it was a rough phase of my life. The patient physical agony that he has significant odinophagia, the deglutition of saliva was impossible. He used to take out the frothy thing from the mouth. We had given him plenty of gauze pieces. He used to wipe it. Okay. And there was an excessive salivation. And on 13th post-operative day, that is 5th day of re-exploration, he developed toxic symptoms. And he died on 14th post-operative day, the 6th day of re-exploration. Now, death is a known complication in esophageal perforation. And this is usually because of the mediastinitis or meningitis. Now, what are the causes of perforation? This is extremely important. Once you see this talk, the next time if you get a fractured spine case, you will try to actually see the X-ray properly. This I'm telling you because I have another case. So the early causes of this perforation is iatrogenic. Okay, injury during induction, intubation, nasogastric tube insertion. Though it is not very common because mostly the senior people they induce the cervical spine. Injury during surgery, during doing the exposure, a sharp operative instrument can lead to injury. Your cautery can damage it. So always cover, the cautery is very long. So always cover with the plastic tube. So only the tip is open. So you don't touch here and there. That is extremely important. And pneumatic burr also, your hand should be stable. Otherwise, if fly off and then it tries to entangle the soft tissue, and that is the disaster. And esophageal wall ischemia. So initially, people used to use just a right angle retractor and, assistant, they used to pull it. If you pull this with the force and try to keep it for a very long time, there may be ischemia of the muscle there. Okay. And you might have read even in the anatomy, there is a Killian's triangle, there is a Killian's deviation. So there, that area is very short and the muscle fibers are not too many. Okay. So there, that is the site of actually perforation because of leak or necrosis in that region. And probably in this case, it was a delayed leak because till 7th day, he ate everything very nicely. There was no problem in the wound, and then suddenly he started leaking. What are the late causes? It is because of the irritation of the prominent implant, or if you have used the bone cement, sometime people used to use in malignancy cases. And if there is a dislodged graft, that can also lead to problem, and backed out implant. If the patient in follow-up, he comes with the, his screw which is protruding out, or plate is misplaced. So these things, and this is well actually reported in the literature. Many articles you will find the so-called iatrogenic esophageal tear might not be the result of surgical procedure, but maybe the cause of initial trauma itself. Actually, this part I wanted to highlight. And see, there are multiple papers which have been already published into that. So what is the common scenario? The patient comes with the cervical spine fracture or fraction dislocation, and there is a quadriparesis or quadriplegia. Okay. You do the reduction, you do decompression, you have done the stabilization. Everything very fine. Okay. But post-operative, what you find, there is a wound dehiscence, and you think there is a operative wound infection, and patient develops toxemia and then he dies. You think it is just because of the bad respiratory status, the chest was bad, and you think it is one of the problem of the quadriplegia, which is not the case. Okay, minor leak might go unnoticed. This is extremely important. I had a case. Now this case, you see, you are seeing that anterior chip fracture of that body, and you see the MRI here. Okay, and this was a hyperextension injury, and we did this grafting and plating. Everything was fine, and now see there is a esophageal leak because we did this barium swallow, and this is showed that there is a leak. Okay, barium swallow is important. You can diagnose it, and you see this chip. Now you can revisit and see your MRI that there was actually evidence of soft tissue injury which we did not notice. Okay, what is the cause of death in this esophageal perforation? It is because of mediastinitis, septicemia, meningitis, and incidence of esophageal perforation is 0.02 to 1.49, and the mortality is it is high. So one should try to know the treatment, very careful. One should try to manage this case, and most of the time you will be able to come out of this problem. This is extremely important for anterior surgery. So suppose you diagnose, how will you approach this case? So usually you should put the methylene blue, and if there is a leak, then you will find your gauze piece is stained here. So that even there is smaller leak, that the staining will be there, because when there was a swelling, you gently open it and you find, yes, there is a leak. Okay, now what to do? You can do with a contrast esophagography. You can note the size and site. Then you can do CT and you come to know an endoscopic examination. Intraesophageal, suppose you want to do the re-exploration, you can even put the dye in the esophagus in that area, and you can identify from where it is coming. That is another possible thing. Now, when there is perforation, the treatment is controversial, aggressive versus conservative, and it is very highly case specific. Now, what is the role of conservative treatment, and when one should consider it? If there is a very small contained, defect, less than 1 centimeter, no or minimal mediastinal contamination, no pleural contamination, no signs of septicemia, stop oral feeding fast. That is extremely important. Put rice tube, and this rice tube feeding should be with a hypercaloric diet, never through the neck, which was pushed in the first case, which I had just presented. Intravenous sensitive antibiotics should be them, broad spectrum antibiotic, it should be. Liberal wound drainage, just open the wound, don't put anything, just squeeze it, it will come out, and gradually you find that the wound is started healing very nicely. You are putting in a rice tube, and feed is going to be given through the rice tube. That area becomes dry very, very fast. And then healing also in this region is very fast. So after 1 week, you start semi-solid. Liquid last, because liquid will seep. Okay, so this is extremely important. And what is the surgical treatment? You can do primary repair, and primary repair with the flap enforcement. Re-exploration should be done by first surgeon. If you have done the surgery, you should wash up, because you know what have you done, and you will be able to dissect it nicely, separate it nicely with all due care. So you should be the first surgeon. Make it a point. And if at all you want to involve a GI surgeon who treat esophageal malignancy. Okay, so that should be the person who is going to handle this case. And you can reinforce with the different type of flaps. The commonly used is sternocleidomastoid and pectoralis major. Okay, actually these two are sufficient, but the local thing is very useful. Pectoralis major, again, you have to involve the plastic surgeon and all. So you can use sternocleidomastoid and longus coli, which is very nearby, and you can put a flap on that. Okay. So I'll conclude. You must have very high suspicion, early detection, and you must start prompt treatment, and then you can get then fruitful outcome. This is a very important thing, and more you do anterior surgery, more and more precaution you should be taking. Thank you very much.
Any question for Dr.?
Yeah, any question, please ask me. Yeah.
So my question is, suppose you are dealing with this case, due to trauma. But you see there's a post-traumatic, you are, would you prefer a vertical?
Yes, yes, because then you will able to actually see the whole thing very nicely. So you have to plan. That's why I told each case is different. If you see it is very minorly, it is there, you just start rising. Most of the time, and after when I lost this case, I have a group of friends, I'm telling you, due to this case, many of the GI surgeons, they become my friends. And they used to do very routinely, they used to pull the stomach and, for this esophageal reconstruction. And one of the fellow, I'm sorry, he's no more in this world. He told, don't worry, start on biscuit, it will be all right. The biscuit has a lot of calorie and biscuit has protein also. So put the rice to, don't worry and forget about this one. This is going to hit because I treat daily such patients. And I'm telling you, there is a very nice way of treating this esophagus. Minor thing, contain, you just put rice soup and stop oral feed. Will hit. If it is a centimeter, then you should be worried because you have to then suture it. Okay? You have to suture it and you have to reinforce with a sternocleidomastoid or longer stem. Thank you.
Hello, Vishal. Hello, Dr. Vishal. Hello, Dr. Vishal. Hi, can you hear me?
Yeah, Vishal.
Yeah. Give us your commentary. So basically, there is an issue. I can't have a serum to check the level where I'm docking. So I felt I was docking at 2-3 instead of 3-4. So usually what we do is I take a deep fascia 6 over the 4-5 and then just go upstairs and do it. But because we come in and I fear that I may be in the wrong level, removed our previous doctor and now we're putting it back again at the same place. So it wasn't the wrong area, it was just that I was wrong myself. So I'm just now opening the cassette here. I'll get your microscope in so you can have a look at what is happening. This is the next level, that is the 3-4. So T-lift at 3-4 and 2-3 are a little different than T-lift at 4-5. And just as this is also fairly stenotic. Is it right? Any questions we can keep asking, I can answer because right now, unless you see what I'm doing inside.
So with the tube there, we didn't check. It was. So we didn't check through the IIT.
I usually check and say, I can't hear, so I'm being more vigilant. I thought I was at the wrong level, I wasn't. But I thought,
Okay.
I kind of opened up from below. Okay, I'm in the correct place. The talk's finished there now.
Yeah, they are on. So we had some time here, so that's why
We are trying to catch you between the two talks. Okay, give me 2 minutes and our microscope will be in.
How different for 2-3 and 3-4 is for completing?
So the disc is at a different level and the kind of you go downwards, 3-4 is going to be still straight. So we'll get a microscope in that way. It's a very ugly incision. I'm sorry, I'm not used to a quadrant. I use a concept, and that's more kind of stiff. Otherwise, I use a 24 mm matrix. But with a quadrant, I would have taken a different incision to get it, but this is what we have. Okay. Dr. Vishal, yeah, will now have one more talk and then we'll come back to you after this talk. We have Dr. Hansal Bajaj, who is a renowned psychiatrist, and he is here to give us talk on the somatization as I announced earlier. Everybody would have listened to the Amitabh Bachchan song, Ami Tumo Ke Balovasi. Hun tamne prem karu chu. There are different languages he sings in that song. So, in spite of this or in spite of that, I love you. That's the title of the book Dr. Hansal Bajaj has written. Kata par hun tane prem karu. That's the title of the book. It is written in both English and Gujarati. Men are from Mars and women are from Venus. People must have read it. If not, I think it is the book. And similarly, this book is also the equal importance. So Dr. Hansal Bajaj is here with us. Let us upload him and let us have him for the talk on somatization. Thank you. Thank you. While we are waiting, question to Dr. Shrivastava, sir.
Yeah.
As you said about the clinical evaluation, and you can predict from the. Are there any studies to support that? I mean, have you?
Yeah, I showed you list of studies.
Yeah. So,
List of studies that when you see, so first thing you can, if you want to do the minimal imaging, so there you can go for CT.
Yeah.
CT will give you enough idea. Contrast CT also will go. If not, the methylene blue is one is the which is cheapest, and it will show definitely if it is an open thing. But if the patient has come with a trauma, if you don't want to do anything, you at least do CT and contrast CT. So that will give you an idea. Yes, there is a problem, and you have to be cautious when you expose. See that when you are taking out that fragment, whether that fragment is stuck with that. So try to dissect proximally and distally, and then gently try to lift that area. That will give you enough idea about, and see that if there is any rent in the esophagus or there is an opening into that.
Sure. We have to thought of looking at the vertebral artery, because this is sometimes the vertebral artery thrombosis. It's
Yeah.
also very well known.
Yes.
So I think let us introduce that also to the.
Yeah.
To the
So actually, I had case of vertebral artery injury with the problem in the brain, and that is one entity. And from that case onward, I started seeing vertebral artery in all these trauma phases. So many a times, one vertebral artery is sufficient. Patient doesn't have any problem. But if you see the axial cut, you find that one side it is not visible. It is white. Maybe it is thrombosed. Okay. Another side is a patent vertebral artery. So you will find now that whenever you see the axial cut of the MRI, try to see the opening of the vertebral artery. Otherwise also, normally also if you see the vertebral artery in axial cut,
Many times you find that one side is dominant, it is wider as compared to the lumen, which is narrow. So I had one case where there was a problem.
I also encountered one the unilateral pressure dislocation. Even it is not reported by in MRI, I noticed in Excel file. Later on, we did angio. And we postponed the spine surgery to some canine because neuro is somewhat normal. And after giving an antiplatelet and robotic, then later on we did a surgery. And we don't want to handle it. It's already.
Let us hear from Dr. Harish Rawal.
About the complication of esophageal tear. I operated my brother after the accident in presence of Dr.S. And I went back to the United States. And 3 days later, I got a call that when he drinks the milk is coming out. He had already developed and I said, I had a high volume surgery. I have never had anybody esophagus injured. And how did I do on my brother? It can't be, just can't be. And it turned out, then we had to find an ENT surgeon, and we found a cancer surgeon who was willing to look into that. And he was here. And we found that he had a pharyngeal tear and for them to intubate my brother. He kept on doing it, injured the pharynx, which I could never see because I was operating at C6-7 level. And that's it. Very rare for him to have a high fistula. Anyway, he paid it and it worked out very good. The one thing that you mentioned about the injury from the instrument, my boss who trained me always made sure that when we put the retractor, the blades has to be in the longus colli muscle. Either you will perforate the carotids on one side or the esophagus on the other side. So make sure when you put your retractor in the longus colli dissection, so the blades can go into the longus colli.
And usually it is my practice, usually we have this hand, hold retractor. So I put a wet gauze piece, okay, wet gauze piece, and the whole flap is retracted along with the wet gauze piece. Dribbling wet gauze piece. So when you try to retract in this area, your vascular component is on the lateral side and visceral component is on the medial side. So you put a wet gauze piece and then you put a right angle retractor. The core part of the right angle retractor, it hinges on the reflected longus colli. So that much it gives enough safety. Then your instrument, suppose in case there is a slip, it will hit either the right angle retractor, and even if there is a protection with the gauze piece. Another thing, when you go near the cervicodorsal junction, you have the gutter which goes down like this. That is the direction. The best way is to just put a long roller gauze piece and just push it down. So it will, in fact, along with that, it retracts the esophagus or the lower part of the esophagus. Many times you do this ECG where you put the Casper screw, and on the Casper screw you put the retractor. So sometimes there is a distance between this retractor and this Casper screw, that nut part, and in between it comes out, and then you press it. If the esophagus is there, you will cross the esophagus. So it is better to put this roller piece, okay, so that it keeps it away. That part is important. So protection is very important. As you see your complication, more careful you become. In cervical spine, always be near the patient when patient is being intubated. Okay, you never leave that part. So head should be under your control. You in the patient, because simple cases of radiculitis, it is okay. But in cases of myelopathy, patient can become zero if there is a jerk in the neck. So this is your care. He has been admitted under your care, and you are 110% responsible for that. Okay, so it should not happen that yeah. That, left part. So always during intubation be there. Sometime if the junior anesthetist they are inducing, suddenly they give a jerk extend. They want to extend the neck with a jerk. Already there is a very narrow space in the canal. And that single jerk can lead to problem. And H is capital, rest all one digit.
One is the H capital. Okay. So everyone will now know.
But I will not change it.
Sir, I have a question. So for the vertebral artery anomalies that we encounter, we use 3D printing preoperatively for planning.
So see, if you do CT angio, you know that there is a problem. And use the alternative, no? I just now we discussed. Instead of passing the pedicles, we pass the landers too. Provide to take this. And sometimes you are able to do the passage as well too, even if it is there. If this large size, absolutely that part is sclerotic. In that case, you will not be able to use. Otherwise, it is a borderline case. Again, use the same technique which I follow. Each size, tap we keep on increasing. 2.5, 2.7, 3, 3.5, and you will able to pass it. And just retract the vertebral artery in that area. You put your this pencil. You are able to see.
Copy.
We can move to Dr. Vishal. Can we?
Yeah.
Ganesh bhai? Hello?
Yeah, we can hear you.
Yeah, okay. Okay, we are with you now. Vishal bhai, we are with you.
Yeah, so I just orient you what I am finished with now. Try to be correct. This is the head end, medial, lateral, inferior. This is where we did it previously. Take it out. So that's the part I try and tease out. It's a little bit more springy. Can you listen, please? Angle quickly. In the button, no? This.
Yes, we can see you, yes.
This is number 4. A Cambian triangle like I usually prefer to do, bone. I to do my job through that. It's a little tougher here because the distance is much higher compared to what you would be when you do most of your stuff at 4, 5, 5 and 1. But then, yeah, you can still do it here. It becomes more challenging at 2, 3 and 1, 2. Yeah. So, bipolar ready? Give a bipolar. Can we get the height of this up so that we can focus a bit?
So
Can we reduce focus? फोकस का स्पीड मेरे ख्याल से 50 के ऊपर है, कम करो।
Vishal, this is the second disc preparation, is it? Okay, Vishal?
Yeah,
This is the second disc preparation.
this is the second disc phase.
Okay, okay, we'll have one more talk and we'll come back to you. Yeah, sure, thank you.
Right, focus का speed कम करना बेटा. 30 तक रखो, बहुत ज़्यादा है.
Good evening. Sorry for initial issues with the laptop. First of all, I would thank Dr. Bharat for giving me this opportunity to share my views on a very important topic, that is somatization. I'll discuss about this topic in a very brief, and I'll take almost 15 minutes. So today's topic of discussion is somatization. Hello. थोड़ा रेज करो. हेलो. थोड़ा रेज करो. हेलो. So how many of you are aware about this term, somatization? Very nice. So almost everyone is available. Everyone is aware about this somatization. So let us start straight away. What is somatization? Somatization is basically a term used to describe physical manifestation of emotional or psychological distress. This is a simple definition of somatization. Now, if we look at the phenomenon, then it's a very complex phenomenon where a lot of biological and psychological factors are involved, because, somatization is just only some somatic symptoms which does not have any organic basis. But into that simply looking thing, there are a lot of biological and psychological factors are operating upon. This somatization would present as a wide range of symptoms. The most important symptoms are pain in the various regions. If we talk about the pain in a somatization, the two sides are very important. Number one is headache, and number two, backache. These are the two very important pain-related symptoms in the somatization disorder or somatic symptom disorder. That is what we call in latest diagnostic system. There are other pains also which can be involved as a symptom of somatization. That other pain would be chest pain, then abdominal pain, limb pain, all those kind of pain which does not have any organic basis, or almost all the investigations would say that the person is absolutely normal and still he is experiencing the pain. Then we should think about the possibility of somatic symptom disorder. So pain is one of the very important symptoms. Second is fatigue. There is an entity where people keep on complaining about the fatigue, and you investigate thoroughly and you don't find any cause for that fatigue, then it can be a somatic symptom disorder. Lot of gastrointestinal issues, particularly gas, dyspepsia, even sometimes hyperacidity and indigestion, constipation, all this can be a presentation of somatic symptom disorder. And certain neurological symptoms, particularly giddiness, vertigo, even sometimes a vomiting which looks like a neurogenic origin, but that is basically because of somatic disorder. So Somatic symptom disorder have a variety of the symptoms, but these are the most common one which I have just discussed. Now, what we need to understand is about the factors that contributes the development of somatization. This is very important because if we have this thing in our mind, then we would be able to differentiate between the organic pain and the somatic pain, which has no organic basis. Number one, the psychological reasons. There are a lot of psychological factors where somatic symptoms will appear. Suppose if we talk about the backache, then, backache, if you don't find any relevant finding for the backache, or you might think that the symptoms are more than what the defect is suggesting, then this could be one of the possibility. The underlying disease maybe, or underlying psychological factors might be anxiety, number one. With anxiety, there are a lot of muscle spasm and muscle contraction, and because of that, there is the resultant pain would be there. Second important thing is depression. Depression is basically a mood disorder where the person's mood remains low and person may experience a lot of somatic symptoms. And other mental health conditions like illness anxiety disorder, which was popularly known as a hypochondriasis. And second is a hysterical conversion disorder where you can find no organic reason, but still you get a plethora of the physical symptoms. So they are considered as a psychological symptoms. Second is the childhood trauma. In people with the childhood trauma, it can lead to physical symptoms. Suppose in a childhood experience, if the child is frequently beaten by the father or a mother, and if that trauma remains, then that would be reflected as a pain in the later part of the life. Or even sometimes the childhood is very tense, then a lot of anxiety and boredom and other thing would be there into subconscious mind, that would be reflected as a headache in the later life. So whenever you investigate for a person having somatic symptoms without any organic cause, then you should always examine their childhood experiences. Genetic factor, it runs into the family. Most of all psychiatric conditions runs into the family. So we should also take a very detailed history of the patient to find out that whether there is a similar complaint in the family, or sometimes it happens that there is a past history of similar complaint into that family at that particular age. So suppose if some young person coming with the backache and you come to the conclusion that it is nothing but a somatization, then you should try to find out the history of somatization in the parents during that age. So genetic factors are also very important. And finally, the cultural factors. Cultural belief and attitude towards the illness can also influence the somatic symptoms. In India, it is very important because we are basically a physically minded people. We are not a psychological minded people. So most of the time, even we have a psychological issue, we talk in the physical terms. Suppose if housewife is getting a boredom, and if she is bored of her routine, or if she is suffering from depression, then she would not come and tell you that I am feeling sad, or I am, I am feeling bored. But she would come with the complaint of headache or a backache, because that is a more acceptable complaint. If she says her husband that I am feeling bored, then she would get a lecture, why she should be feeling bored. Or if she says that I'm having a sad mood, then also, most of the time it is not acceptable by the other family members, because they would always tell you that there is nothing to be feel sad about the things. You are getting everything, and you are, having a lot of comfort in the family, and why you should feel sad and all those stuff. So in spite of talking in a psychological language, they talk into the physical language that I am having a headache, I am having a backache, I am having a pain in the abdomen, or I am having a dyspepsia, indigestion, constipation. So such kind of symptoms keeps on appearing, and particularly giddiness is also another important symptom where, it is a symbolization that there is something happening at the emotional level which make them giddy, and that is why there is a complaint of giddiness. So these are the 4 factors which is very important when when we evaluate the symptom somatization disorder. Now I am going straight to the management of this somatization. In management, the first and very important thing is a psychological intervention. In psychological intervention, the most important is a cognitive behavior therapy. Cognitive behavior therapy is a kind of a psychotherapy where we address the person's cognition, the way they think and the way they feel should be addressed. And if we make them realize that it's basically the origin is between 2 ears and not at the site of the pain, then probably they would start understanding their symptoms better. And once they would start understanding their symptoms better, then there is lot of reduction in the fear, lot of reduction in the anxiety. And if the anxiety would be reduced, there would be a muscle relaxation kind of a thing, and the pain would start going down. So basically, the psychological intervention and CBT is most important to change the mindset of the person and make them to realize and make them to aware about their symptom origin. And probably once they are aware about the origin of the symptom and they are convinced, second thing is very important, because even if they are aware, but if they are not convinced, then there would be a problem. So during that therapy, we try to convince the patient that this could be the only reason for their pain or discomfort, then probably they would improve. So that is about the psychological intervention. There are people who would not be ready to take a psychotherapy, or who would not be ready to, go into the session because they are afraid that lot of things will be digged out, or lot of their personal thing would be exposed. So they would plainly deny that we don't want to go for a psychotherapy. Or there are people who would not like to wait for the result, because psychotherapy itself would take time, because you are challenging their thoughts and you are trying to solve their emotions. It will definitely require some time. So there are people who would not have that much of time. They will immediately tell you that, doctor, please give me some kind of pain relief and I'm okay. So in that case, we start using medication. Medication, the most important is antidepressant, and another is anxiolytic medicines. Antidepressant, if you go to the pain physiology, then the antidepressant which acts on a norepinephrine axis would be more helpful. So most important and currently available is duloxetine. Duloxetine, they are also promoting to the non-psychiatric consultant as well, because of this particular quality of duloxetine, because it is SNRI. Mainly, chiefly, it is acting on a norepinephrine system, but it does have action on the serotonin system as well. So antidepressant is one of the most important, duloxetine, or even you can try venlafaxine, mirtazapine. There are a number of the antidepressant, but according to me, I would always advise you to use duloxetine, because mirtazapine can cause a lot of weight gain to the patient, which is not preferable in our cosmetically oriented world. So we try to avoid mirtazapine. Same way, if you use venlafaxine, it produces a lot of sedation, and that is also again a problem. So duloxetine should be a good choice. As far as the anxiety is concerned, there are a lot of anxiolytics available. I have seen that most of the non-psychiatric consultants are using alprazolam and atizolam and other things are more frequently, but I would suggest you to use a long-acting benzodiazepine, because if you use a long-acting benzodiazepine, that dependence liability would be lesser one, because it remains for a longer time. So even if the person misses 1 or 2 doses, they will not have a withdrawal symptom. But if you use alprazolam is a wonderful anxiolytic, but you should not use it because it is a very short acting. So even person misses a 1 dose, his anxiety will shoot up, and then he will have a feeling that ye dawai ke bina mujhe chalega nahi. So we don't want to give that feeling to the patient. So use the long-acting anxiolytic. Even lorazepam is also better. People using zolpidem for this, but zolpidem is not an anxiolytic, it's a hypnotic. So zolpidem would not help in relieving the anxiety, it may produce the sleep only. So these are the few important medication which we use in a somatization. The third important thing is mind-body therapies. This is also very important as far as the somatization is concerned. Mindfulness-based intervention like mindfulness meditation or just simply practice of mindfulness can help them reducing their pain. And yoga. Yoga is basically a stretching exercises, but when the person does the yoga, they don't get the benefit because they use it as a exercise only. It's not an exercise. It's basically connection. So if you cannot develop a connection within your mind about the posture which you are acquiring, then the benefit would be very less. Then benefit will be only of exercise. But when you try to connect your posture, when you try to connect your yogic posture to your thought process or to your mind, then probably the maximum benefit would come. So mind-body therapies are very important because most of the somatization disorder are chronic disorders. And if they are chronic one, then naturally we will concentrate on non-pharmacological techniques. So mind-body therapy is very important part of the therapy. And obviously, lifestyle changes should be there because whenever any problem which is related to the stress, anxiety and depression, lifestyle changes would always help. Healthy diet, regular exercise, getting enough sleep, all these things are very important. Education and support. As I told you, that person should be aware that why he is getting this symptom. If you educate them properly, then probably they will become aware. And education should not be limited to the person who is suffering, but their caregivers also need to be explained. And sometimes even other healthcare professionals also need to be explained about their condition. Now, there are few challenges which we can face during the handling the somatization. Number one, and this is very important challenge, that misdiagnosis. Most of the time, I'm not telling you that somatization diagnosed as an organic disorder, but I'm telling you about the diagnosis of somatization itself, because most of the time it becomes difficult to diagnose that symptom because people can exactly mimic the symptoms. And now because of the Google, people keeps on Googling, so they even get certain ideas about the disease which they have conceived in their mind. Suppose if the person is having a backache and if he has conceived in his mind that I have a slip disc, then he will try to read about the slip disc. And then the symptoms which they will read, they will start imbibing because basically they are somatic and very vulnerable to the suggestion. So that would act as a suggestible suggestion, and then they will start developing those symptoms. So sometimes it will become very difficult, and then when you investigate, you can find some certain minor changes and certain small changes in the report. Then you would be always confused that if that changes are there, and if the patient is complaining out of the proportion, still you would not leave any doubt. And that is why you always think about the organic thing, and probably there the misdiagnosis would come. Second is stigma, how to disclose. There are many surgeons I have seen that they absolutely know that the person has got 100% psychological illness, but still they will write down antidepressant, but they would not refer them to a psychiatrist because they are afraid that the patient is not going to accept this because of the stigma. So rather than losing the patient, they try to manage with the antidepressant. And if some part of the symptoms are being managed, then they gradually and slowly disclose to the patient that, see, I have tried my way, but you need this. So stigma is one of the greatest hurdle while we are facing this somatic disorder. lack of awareness is also one of the very important thing, because when you try to explain this thing to the patient, most of the time, lack of awareness about the mental health and mental illnesses, people will resist. Even sometimes it is a lack of awareness on the part of the healthcare professionals also. So basically, all people should be sensitized towards the awareness of this mental health and mental health issues. Then probably this kind of challenge can be managed. So in conclusion, number one, somatization is a complex phenomena, and it can be a challenge to manage. Second important thing, which I again want to tell you in the conclusion, that it requires a multidisciplinary approach to address the biological, psychological, and social factors which contributes to somatic symptoms. Of course, by providing education and support, psychological intervention, medication, lifestyle changes, this can be managed. And finally, lastly, which I told you, I'm repeating that same thing again, that healthcare professionals should be aware about the somatization. They should be aware about the treatment options available and challenges which they are going to face while treating the somatization disorder. Thank you so much. I have kept my presentation very small and brief. So if you have any question, you can tell me. Otherwise, yeah, please.
Thank you very much for a nice talk. The somatization, I think we are coming across a lot of patients with having this kind of symptoms, specifically back pain or neck pain. And you have mentioned some sort of, there are some points to ponder and followed by your response, sir. So you have spoken about some sort of medical treatment. However, I have found that in somatization, apart from medical treatment, there are a lot of other treatment, and specifically you have mentioned about CBT, cognitive behavioral therapy, which comes under the neuroeconomic theories. If we read a book about Daniel Kahneman, Thinking Fast and Thinking Slow, so basically it addresses two systems. One is rational, which is slow, and one is intuitive system. And when the patient come across this kind of somatization syndrome, then initially their intuitive system will think that I can't have this kind of disease. I am not that kind of person. And rational thinking also tells that I am doing healthy job, earning good money, and still I am suffering from this disease. So what is your take on that particularly part of the cognitive therapy? And second, I think few days back, I was listening to TEDx talks regarding this kind of theories, and they have mentioned to tackle this kind of specific issues, which is more related with the psychology. There are 4 important parts I think you have mentioned. First is healthy diet. Second is regular exercise. Third is meditation. And fourth is at least 8 hours of sleep. So these are non-medical parts. So what is your take on that, and what is your personal experience, sir?
See, this was a theoretical discussion, but if I tell you practically, most of the people would not agree to go for CBT because, you know, it's a lengthy process. So, and in CBT, suppose if they agree to go into the CBT, even they should have a psychological mindedness, because there are people who would not have a psychological mindedness, but if family people will pressure them to take a CBT, then they will sit with the negative attitude. So they are not convinced about the illness and about the causes of that illness. So in CBT, our first session would be with the creating an awareness, psychoeducation. That is the first session. So during that session, if they are educated, if they start believing that this could be the reason of my pain or this could be the reason of my symptom, then probably the psychotherapy would work. Otherwise, the psychotherapy would not work. That is one thing. Second thing, non-pharmacological treatment is something everybody wants to do. but there is no commitment, there is no consistency, and that is why we don't get the result. Suppose people would always come and tell you कि साहब दवाई नहीं लेनी पड़े ऐसी कोई बात बताओ. Then we can always say that you do a regular exercise. I'll do it. And then after 1 month, 2 months of the follow-up, if you ask them, then they have not started the exercise. Similar thing would happen to the 8 hours of sleep, or similar thing should happen with the meditation and all those things. So people talk about the non-pharmacological measures. They want to go for that, but they don't have, probably the intention. So missing link is implementation. They are not ready to implement. So ultimately we shift to the medication, because all the time you feel that you have spent 15 minutes, 20 minutes with the patient for 2-3 occasions, advising all these issues, and they are not following those things. Then ultimately you will think that let us do it in a 5 minutes and get the another patient.
Thank you, sir.
These various drug combinations like duloxetine is available with pregabalin and multiple combinations. So they are being prescribed by the representatives that we can give for long periods. I just wanted to know how long can we actually safely prescribe this medication before we consider it a failure, treatment failure.
See, treatment failure, 6 weeks is a sufficient time. If you prescribe that for 6 weeks and if you don't get the result, then probably you should understand that these drugs are not working, and then you should remove gradually. Most of the time, the problem with the pharma people, the combination is not of a right dose. It is always a miss combination. Suppose if you go to the duloxetine and pregabalin combination, then it would be a 30 plus 75. But you straight away give 30 milligram of duloxetine, patient is not going to accept it, because there are a lot of GI symptoms and a lot of serotonin surge would happen. That person would become more anxious. So ideally, if you want to do it, don't give the combination. Because duloxetine, you should start with the 10 to 20 milligram and gradually go up to 60 milligram. Same way, the pregabalin, you start with the 25 milligram and gradually go to the higher level. Then I think it would be more acceptable to the patient rather than, the initial rejection of that treatment. Thank you so much. Thank you.
Let's go live already. Give me 10 minutes with them. Yeah. Please. So we'll be having 10 minutes. Yeah, go on. We'll have the live.
Yes, Dr. Vishal, are you there?
3 mm.
Yes, we can see that, sir.
Yeah. Because already the distraction has happened. I'm just trying to get the soft flavor, then suddenly, which was very, very loose and tight. But we're having an important discussion, so I didn't disturb that. And now you can see I'm in the opposite gutter there, lateral to the opposite side lateral area. And just kind of doing some cleanup job, housekeeping job there. Start the ballpoint, please. Ballpoint, large, please. Can you see this?
Yes, we can see that.
That's
Nicely done. So still, I think some optimal part you want to address.
This is where we would fix the foramen here.
Okay.
Yeah, okay, yeah. Unfortunately, the increase in after I got it, I wanted to- Yes. Yeah.
Regarding this cage, have you had any bad experience that it breaks up when you hammer it in, or post-operative
Lots of times, especially in the Indian cases of peak, because the repeated autoclaving become very fragile. It was broken. And unfortunately, it usually breaks where the holder is holding. So you can't take it out. So you have to kind of accept it and let it be. Back to metal cages or pre-pack cages.
Right.
Electronics always. So I've asked my Indian cage manufacturer to start giving me that one. Very there.
Yeah, you are right. If you are using thick cage with Indian material, I think it should not be used.
Breakage of cages peak is very common.
Yeah.
Titanium does not happen. Titanium will get a lot of subsidence. So that is something you need to worry about when you use titanium.
So you mean titanium has got more subsidence incidence?
Yes, because it's harder, it's 80 times harder than normal cancerous bone. So you're going to get a fair amount of that if you have taken the entrade out. See, what is happening is majority of the guys are just taking the chamber in and letting the chamber do their entrade clear. You need to use curette. The moment you use curette, there's a good chance of preserving the end plate, and once the end plate is preserved, then the substances are there. But whatever you do, however, when you prepare, you should be prepared for that one cage out of every 100 that is going to subside a bit. So, what is your? I'm done with this level. Are you all happy with what is there, or you want me to go ahead and do some more?
No, I think it's fantastic. I think on both sides you have done bilateral decompression very well.
So I need to do here, otherwise we are done. My ballpoint can go under completely. And it's very tactile, so I'll let it be. Okay, Sridhar, Sridhar,
Shall we go? So we'll go ahead with another talk, Dr. Vishal, and we'll get back to you again. Okay?
okay.
Thank you.
I invite Mr. Rajat Datta for his talk on inheritance will. I'm sure he is going to enlighten us and give us a lot of questions. If I give you my own example, I lost my father in the year 2000, and he had, I think I have lost it. Hello. He had made such an arrangement that my wife Amita, none of us had to go with his death. Everything was so much so, managed in such a way that nothing was required. We just didn't have to take the death certificate to any bank, to anywhere. So such things should happen to everybody. So let us hope we have the best of the best guide, Mr. Rajat. Over to you, sir. Thank you.
Thank you so much, Dr. Dave, and thank you for giving me an opportunity to address. Let me tell you, looking at this slide, I was shit scared whether I'll get sleep tonight or not. So I thought might as well pass on the attention to you as well, and make you equally anxious about what will happen to see about. So the factor that I'm going to say is also going to make you very anxious tonight, because I can't sleep and I think I will not allow you to sleep as well. So let me tell you, who are you? You are born in a family, born to your parents, Mr. and Mrs. So you are born to your brothers and sisters. That's how you have got the birth. So on birth, it creates inheritance. That is the eligibility for inheritance. Now, death triggers inheritance. But there are two exceptions to it. When you adopt a child, the child is not born to your family, but the child becomes a natural heir to your assets. Similarly, when a lady gets married or a female gets married to a family, she gets into inheritance. You all know that no one is immortal. You play with death day in and day out. And I must tell you, life is uncertain, but death is surely certain. Live nothing by chance. You don't say yes, no, tomorrow, maybe sometime, someday. Everybody is going to die. Some of the relevant questions which I think you should start thinking today is, what after me? Who after me? To whom after me? What is the process after me? And who will do it after me? These are going to keep you alive tonight. And believe me, I'm going to tell you what's going to happen. So the typical questions at whatever age. Yes, sir.
Mahatma Gandhi said clearly, as long as you have for your need, not for the greed, all these things will be answered. So I will, then inheritance becomes very easy, isn't it? I thought
Well,
you're from
yes.
Gujarat, next to Sabravati Ashram, you're going to tell us, don't make enough money, lead a happy, wonderful life today and at the moment.
So let me tell you, sir, that whether you make money or you don't make money, without the laws have become so stringent, so your next generation is going to feel the heat. So you better compare yourself and start working. And the subsequent slides will take you through. So the typical questions which come up are: at what age should we make a will? At what net worth should we make a will? But I have all my assets in my joint names with my spouse, and I also have my spouse as my nominee. But let me tell you, sir, nominee is only a caretaker as far as your bank account is concerned. He is not a legal heir. Nominee in a life insurance policy is only a trustee. In case of mutual funds, he is only a custodian. In case of a demat account, is only an interim owner of the legal heirs. In case of a housing society, he is only a custodian. So what you are depending on is actually not the thing to be dependent on. So I can only sum it up in this, that as statutes are getting stringent, if you don't make a testimony document, what's going to happen is that the law is going to decide on who it will go to. So if you are a Hindu, it follows the Hindu Succession Act. If you are a Jain, Buddhist, Sikh, or it follows the Indian Succession Act. Or if you are a Muslim, you follow the Muslim personal laws. And for others like Parsis, Christians, there is the Indian Succession Act. What happens when someone dies in a family? Just think 2 minutes that you would have come across many such occasions. Post-demise, the family undergoes a huge trauma because the surviving spouse has seen a void. Not only that, there are sometimes cash flow issues. Not only that, in reality, the spouse does not know where the assets are. If she knows where the assets are, she or he does not know in what state they are. If she knows both, then they don't know whether the documents are such that it can travel the path of legacy. If she knows all the three, then she does not know who will do it. That's the problem. And it's a fact. Today, we don't have legacy lawyers or succession lawyers in this country. We have a civil lawyer, we have a criminal lawyer, we have a corporate lawyer, we have a labor lawyer, and also they do legacy. So what's the noise about? Will is the only document which is going to be bearing on the wealth distribution and post your demise. You can't afford to make a mistake in the drafting or to writing whether you're owning the asset or not, because there is nobody check. No one can check on your interpretation because the guy who has written it and signed is no longer available. He's enjoying his life or her life in the heaven. So you are now going to follow whatever he has written in whatever the judge thinks is written. Now, no judge in the world is going to interpret a will. He's saying if this is this, it is this. It may be right, wrong, or the otherwise. If it is wrong, he will make it null and void. So I think it's a social responsibility for each one of you. What do? You give education to your children, see that they settle in business or in profession or in vocation. Now it is your social responsibility. You also need to take care of the inheritance for your assets so that it moves on. How do you address it? You address it when you are alive. And how do you ensure protection of earnings and savings and organize that the seamless transmission goes through? When it's all going to be in part of the family, then why don't you take it? We have very short time. You can ask 1 or 2 questions, and please note down my email ID. Please be fair enough to write an email to me, and that will be great.
Thank you. Thank you for throwing us. There are a lot of questions and answers as well. Anybody want to ask quick question? Yeah, please.
Give the answers to the questions that you posed. At what age we should make a will, and at what level we should. Those 2 basic.
Surely, I will give the answer to all the questions that I posed. That's great. What after me? Hello. What after me? You have to decide what after me. If you don't decide what after me, the law is going to decide. Do you want that to happen? Some lady would come and say, he was my girlfriend. What happened to Rajesh Khanna? And then Akshay Kumar had to come and settle the deal out of court. Do you want that to happen? Why don't you decide your assets go to whom? Your son, daughter, whoever. Who after me? That has to be decided by you today. You may make a will and today and you may die 30 years from now. You can change that subsequently. But at least you don't know that tomorrow you may not wake up from sleep. And who else knows it better than you, who are doctors who are playing with death day in and day out, and you don't get yourself prepared? It's ridiculous. Believe me. I want to see that you don't get sleep tonight because you have showed me those slides when I'm not going to get sleep. So you better understand that it is for your benefit, your spouse's benefit. And look at the trauma if you die suddenly that your spouse is not going to. You are doctors. You would have seen people have Alzheimer. They don't remember how to sign. We have acute arthritis. They can't hold a pen. You have money in the bank, but you cannot operate your check because of your acute arthritis. Signatures don't match. Because of kidney problems, I'm not a doctor, but because of kidney problems, your skin has gone down and all your grooves are not seen on a thumb impression. These are factuals of life. You better get prepared. You get prepared for going for a vacation in Switzerland in the month of May when Ahmedabad is hot. You try to Google and find out what is the type of clothing or what is the temperature there. Why don't you prepare for a most uncertain but certain event? It does not give you an advance notice. It just comes here and there you're done. It's time that you think. And you're in the lap of death day in and day out. You've seen more deaths than I have. 25,600 people die every day in the city in India. That's 98 lakhs per annum. It's time. With medication, you have increased your life cycle. Now your average life is 72 years. But you're going to find those stuff difficult in the last 2 years or last 15 years when you're not going to be able to write, sign, think, or act. So better think it over. Yes, any other question?
Is there any it has to be done in the presence of someone or it has to be?
Yeah, so what we have done is we are the only Indian company which runs this service for all asset class. I will just leave a brochure for distribution. Please write all to us and we will be happy to help you out and guide you.
I think you are very well said that today it's today's incidents that the famous hospital, Manipal Hospital in Bangalore, a neurosurgeon who has operated one case and preparing for second case, and he had massive cardiac arrest and he died today itself afternoon. So I don't know the name. I have just received the message today. But my question is like a handwritten will or a printed will, which should be considered in court of law. If we don't prepare will in presence of a lawyer or somebody else, we just write on our own. Is it valid or not?
First of all, let me tell you, I want to tell you a very simple thing that will can be handwritten, can be typed, whatever. But just look at this. Are you lawyers? No. You can write your own will. What is a will? Will is only a death wish. When you attach the death certificate to it, it becomes a will. Till that time, it's only a death wish. If you know where your assets are, how you own the assets and the legality of it, you can make your own will. That you don't have to go to any lawyer. But you should have the confidence that this will be marketable, that the court stamp will be available. If you're not, then get a will prepared by somebody who knows how to make a will. Because what are you doing? You buy a house, you're spending a commission of 1.5% in paying brokerage to buy a house, right? Which is lakhs of rupees. How much does a will cost? X, 1,000, 2,000, 50,000, 60,000. What is that as a percentage of the value of wealth? Why are you toiling so hard to build a wealth and only because you don't want to spend that 60, 50,000 when that is the only document which allows it to go to the next generation? I think it's just peanuts.
I think I have heard from Paresh bhai. Why don't you give that example that, the house was given to X person, but not written the full house word.
Sorry. Okay, let me tell you, that's a good example.
This is the best example.
So you listen to this.
Yeah.
Everybody knows the first family of the Indian film is RK Studios, right? What happens in RK Studios? RK Studio, the question is, why did Ranbir Kapoor sell the house before he got married to Alia? That's the question. And there is a strategy behind it. There is a difference between ancestral house and inherited house. I'm repeating. If we normally use the word, we got it from ancestral. Ancestral house is that house or an asset which comes from your grandfather's grandfather. So, As you know, Alia gave birth in the 7th month, so she pre-conceived before marriage. Now, if he would have married and if Alia would have given birth, then Prithviraj Kapoor, who owned RK Studio, this RK Studio would become an ancestral house. If it would become an ancestral house, then Ranbir Kapoor's share would be less, because then he will have to give it to Kareena Kapoor, Karishma Kapoor, their children, and his children also. He sold the house before it migrated to ancestral status, because at that point, now he stopped Raj Kapoor, 2 sisters and Raj Kapoor. Raj Kapoor, 3 sons and 2 daughters. Each son stopped. Ranbir Kapoor stopped. Ranbir Kapoor, it one share. Then Shashi Kapoor gone, his 1 share goes to 3 people. Rishi Kapoor gone, 1 share goes to 2 people. That's why he stopped. So everybody gets a larger share. Had he married and then sold, everybody would have get, Kareena and Krishna would have get, and his share would have gone down. So if those people having sins on tons of money are thinking that, why are me and you not doing it? Don't you think we have more hard-earned money? They have not hard-earned money as much as we did. You studied so many years in medicine, right? Having done so much in medicine, postgraduate in medicine, still you are grappling to make money and make wealth. And you don't want to spend 50, 60,000 rupees, just allow it to go away. Don't do that. Laws are so stringent. Now there is no interpretation issue. It is yes or no, period. Any other questions? Please write. You have that email. And I have given my colleagues here from Wealth First, who have been kind enough to introduce us to Mr. Dr. Dave, has enabled this session.
Thank you very much. Thank you.
Thank you.
Thank you. We will like to give you a memento, please. Thank you very much. Thank you.
Thank you so much.
Thank you.
I hope you will not do this.
Thank you.
Okay, thank you.
Over to, thank you, madam. Over to Vishal. Hello, Dr. Vishal. Yeah, we can hear you.
Yes, we can see that, Vishal.
Local schools. If it is not available, we'll be using Medtronic Legacy 2. Mila kya? Okay. So we are going to use local Indian made tools with the navigation. Is mask पहनो बेटा. वो किसी कारण दिया. तो टच वन. ये तो बाद में घूमने को नहीं आया इधर. ठीक से रखो, कराइल एटिकेट फॉलो. इसको अंतराल मत रखो, एक बार और भी मसा के ठीक है, जो भी मैं कर रहा हूँ. Healthy in the cages and everything. Yeah.
Vishal, now you're putting the screws.
Yeah, so we'll first take the feed for the navigation.
Okay.
So one will go among the patient, get the basics sorted. We set to the navigation and then we'll go person. So there are 2 ways of doing it. At Stavya, we use Navita. It's a very good way of doing, where you just go in straight with a profile and a tap. That would kind of make the path and directly insert the screw. I'm a little scared of that. So I cannot put a guide wire and do everything with the guide wire because it's more kind of control. Because the only disadvantage with the Navitap is it will give you one way to go. And if in 1 out of 100 your tractor is off, then God save you. So how do you manage to then do?
Have you taken the screen? Dr. Vishal, have you taken the screen?
No, we are just taking the screen. Can the cameraman show us what we are doing? Cameraman ko bula na.
Hello? Yes.
एक मिनट मेरे सामने खड़ा हूं। Okay, so
What was the issue?
पहले lateral है। वरुण को कैसे मालूम है?
No. What was the issue, Vishal, you were pointing out?
Sorry,
What was the issue you were pointing out?
nothing. We're just asking the cameraman. Bhai, come here.
So Gujarati is so fast learning. It took me 25 years.
I am married to a Guju lady for 24 years.
Arey.
For 30, so I better learn. My son speaks Gujarati till he was 4 years old. Okay. So, so, hey, I'm not wearing any. This is the second time you're doing it. Varun, I told you what to do. Square it first. Huh? Okay, I want it in the center. Okay, now do the AP. Please warn us when you're shooting. Buddy, I've already lost hair on my hand. That's the reason we went and bought a Nova. I had too much of radiation and my boss had heavy cell leukemia. Okay, so there it is. So, okay, the school is fairly very corrected. Central. Let's do the thing. Okay, we'll wait outside. So now, are you seeing or can you show them the native screen? Can I come there? Sorry. You'll have to read there because it's telling also still is standing outside. Sorry. We told them. We told them. सर्जरी का एक ही बॉक्स में कर रहे थे इतना लोग रहता है ना इन्फेक्शन भी बहुत आ रहा है उसके लिए थोड़ा डेमो सर्जरी में टाइम वगैरह लगे
Okay, can you zoom in the camera, please?
इन्फेक्शन लगे
Can you zoom in the camera?
quickly
Contrast. Hello. The AP and little both are on the screen, but we can't see it clearly.
क्या हो गया वापस से
Hello, Dr. Vishal. Please lead. Hello, Dr. Vishal, please lead. We move to the next talk, shall we?
Yeah.
I think the last talk, Dr. Utkarsh hasn't come, is he? Is here, okay. Can we have you, sir? Paresh bhai? No, Paresh bhai.
as good as it gets.
You will finish in 10 minutes. Before that, okay. Paresh bhai,
बॉक्स का टीम हमने डिजिटल ग्राउंड क्या पैसा
Dr. Paresh Mehta, he does not need introduction. Most of you will know him. He is our anesthetist and my batchmate. And we had few couples, usually you have the husband wife from the same batch. That is one of them. Let's have Dr. Paresh Mehta talking about young at 60. Done. You're on.
Good evening, everyone. It's absolute pleasure to speak with you all today about the topic that is close to my heart, being young at 60. Age is just a number, and it is never too late to start living your life to the fullest. We live in a world where we are judged by our age. Society and our dear friend also tell us that once we hit a certain age, we are expected to slow down and take it easy. However, that could not be a further from the truth. It is 100% possible to stay young and vibrant even in 60 and beyond. Health is a state of a complete physical, mental, and social well-being. One of the most important things to do in order to stay young at 60 is to stay active. Physical exercise has a numerous benefit, including the reducing the risk of chronic disease, improving the mental health, and increasing the longevity. As you all know, muscle mass naturally decline from about age 30 onwards, unless you do something to counteract. It is never too late to start exercising. Even something as simple as going for a walk can make you huge difference. Engaging in activities such as walking, jogging, swimming, cycling, trekking, or even dancing can help to keep us feeling vital and energized. By doing a physical activity, you lower the risk of many diseases. You can improve your memory, sleep, fewer symptoms of depression also. On 75th Independence Day, I read 75.75 kilometers for the celebration. Another crucial aspect of staying young at 60 is to keep your mind active. Learning new things, whether it be a new language or a new hobby, can help your brain sharp and improve your cognitive function also. It is important to challenge yourself and keep your mind engaged. We should not fight with our biology. Our biology is our biology. We need at least 7 to 8 hours of sleeps at a night. When we are not getting that, all sorts of bodily functions can be disrupted sooner or later. That is 100% sure. We can prevent mental illness by practicing meditation, breathing exercise, avoiding comparing ourselves with others. Our Prime Minister sets an example for us at this age also. Don't hesitate to take a professional help from the psychologist or psychotherapist. We have seen that many of our colleagues, friends, and relatives needs professional help for their mental illness. But because of the huge stigma, they don't take help. Please convince them for the professional help. Staying young and staying socially active is also important for the maintaining youthful spirit. Making a new friends, practicing a community event, and most importantly, spending a time with your loved one can also help to improve mental health and overall well-being. Of course, it is not just about the physical and mental health. Taking care of your appearance can also help you to feel young and vibrant. Eating a healthy diet is equally important. Before 14 years, I was excusing myself for exercise because of being an anesthesiologist, as the time is not in my control. Then I started going gym at even late evening. Started taking a part in 10 kilometers runs, then half marathon. Started cycling before 10 years with well-known spine surgeons, Dr. AJAY KRISHNAN cycle. Now I have a carbon frame cycle also. This picture is our ride to Nalsarovar with dear friends. More than a health benefit, I got another benefit also. I made a new friends all of age. We are spending a quality time together, enjoying different festival at our favorite place, riverfront. Tea is tea. One of the best time during the workup is a tea time. I also developed a photographic skill. Nature's beauty I could see and I could capture rare and beautiful natures. I developed some photographic skill too. This is the most cherishing moment. Back to home with each medal, and my mother is so happy, as she was when I was a kid. My biggest dream was to reach Everest Base Camp. That I prepared myself and reached and climbed the Everest Base Camp. I am proud to be a first Stavyan to reach there. Few of the cherishing photograph I have taken during my journey at the Everest Base Camp. Not to forget a gifted, passionate Dr. Bharat, who himself does not push the limits for the physical health, but creates a platform for the everyone and understand the importance of the physical health for the muscle and bones. He softly talks enough in a day and stands to spend his calories silently. He finds his passion in spine exceptionally. So in a workplace also he wins. In addition to all these factors, having a positive attitude toward the aging is crucial. It is important to remember that aging is a natural part of life and there is no need to fear it. In conclusion, age is just number and it is never too late to start living your life fullest. Thank you. He doesn't take any diet.
Yes, work hard.
Small frequent diet. He never eat, and he always tell me, whenever I eat, if anybody comes and tell me, start again eating, I can eat again same amount of. So nearly eating 30% of whatever he needs.
I've never seen him eating. Any other questions anybody wants to ask?
Can I make a comment?
Yeah, please. I'll give you.
You know, I was buying an at the age of 37, I was buying an insurance. At the age of 37, I was buying an insurance policy, and when the blood tests were done, my blood sugar was 254, and I found out that I was diabetic. Since that day, I went home and I took 30 pounds off in 3 months and started walking 4 miles a day. And then as I got into the rhythm, I would not go home. And you know, our weather today it is a 6 inches of snow where I work and where I live. I would never go home without running for 5 to 6 miles every day. My first marathon, first half marathon, 21 kilometers, was when I was 59. And when I had half marathons, till I had to have a cancer operation and I had to stop running. I still walk 10 kilometers a day, and I'm 75. So you are never old, and please do it because it will keep you healthy, more stimulated, and your efficiency will increase.
Yet to dye your hair too.
I don't dye my
That's
hair.
what I said. Yet to dye your hair. That is also equally important, you know. Thank you. Thank you for giving such an insight. Parishbhai, thank you very much. Thank you. We have to reach Radisson soon because the hall is not going to be available for us after 10:30. And we especially wanted to have different kind of food than just that food from our local food. So that is why we arranged that. And in order not to lose you all, I arranged the quiz as well. And the talk of Dr. KRISHNAN as well. So let us see live for a few minutes what has happened there. And then after that, we all can move to Radisson, which is not far. If you need vehicle, there will be people who will be, all of us will be going and we can provide you transport as well. So please do not miss today evening dinner. Please. And it's been specially arranged. And Dr. Ajay's talk as well. And we will have Dr. Neurophysician talk tomorrow at 4:30. He gracefully accepted that he will come tomorrow since we overran today as well. Thank you. So over to you, Dr. Vishal. Vishal, you are live.
Yeah. Hi, again. This is like a serial of olden times that goes on and on and on. Somebody would, we are just waiting, this is,
Punishment.
It's frame नहीं है मेरा. नहीं, frame नहीं. Axial, lateral, and the lateral taken before. Marker to me. Marker to me. Extension. So this is length up. So can you all see this?
Yes.
Second, right? Hey, you had the patient was breathing when you took this. Okay. This will be less by Varun. That's a coming cut. बस बढ़ाओ कितनी आता 40 है ना as ready बढ़ाओ why are there two images then if we were saying ठीक है so this will put through that will be wire इधर चादर डालो एक छोटा
He made our first win in 2006 when we all went to England for a family trip. So, you can have it at any age. 2006. Well, no, at that time we have done again because we had, few things. Have that, in future what to do. And then you just need, and if you want to notarize it, you may not notarize it. As you said, your wish will become will after you die.
There are 3 cities in India where your will to be notarized.
Sorry,
wire एक सादा क्लॉथ वायर कपड़ा
India.
दोनों जगह लगेगा इससे नहीं होगा कपड़ा लगेगा not this
There are 3 cities in India where you have to notarize your will. Like, yeah. I think Bombay, Chennai, and
इसमें जा रहा है टैप में लास्ट टाइम नहीं जा रहा था
Vishal, any tips to avoid any artifacts? Keep the.
We should be basically doing it with apnea. I think the patient was breathing last dilator. Hammer. Towel चाहिए मेरे को. Plastic से नहीं होने वाला है. So I'm using this to. She's a very short stature lady. So you know the difference. Is barely measuring 40 size screws.
It is the same facial slit you are using, or it's a different track?
I have closed the fascia and I have just subcutaneously I'm going on the side. What has happened is both the things have combined in season. And it's a big one, so I might as well try to make less. Okay. Varun looks okay. So that yellow thing is the projection. And the blue, can you see the images on the tracker?
Yeah.
The blue is where the true needle is. So I'm just kind of following the yellow projection path. Hammer to me. So this is also 40 now. I'm going to go a little more superior because there is, if you see, there are two images. So there has been a breath that this patient has taken. whatever it is,